Today, I'm going to start by asking you to use your imagination. Imagine you are one of the 12.2 million individuals enrolled in both Medicare and Medicaid, otherwise known as dual eligible beneficiaries, or duals for short. You are 72 years old and became dually eligible about 6 months ago. Like many duals, you have several chronic conditions and have to take many medications each day. You also struggle to keep up with your housing payments and put food on the table. Unfortunately, you are not alone in this respect either. Beyond having greater healthcare needs than non-duals, research shows that duals are more likely to experience social risk factors, such as homelessness and food insecurity. They are also more likely to report being in poor health. While this information is generally known, there are other critical disparities that point to a dire need to advance equitable, person-centered care for this population. Research shows that beneficiaries from communities of color are disproportionately represented in this group, and that they experience additional barriers when navigating Medicare and Medicaid. We also know that while duals as a whole are more likely to be hospitalized from COVID-19, Black dual eligibles are more than twice as likely to be hospitalized when compared to their white counterparts. Although there isn't enough time to delve into all the ways we can advance health equity for this population, I want to share a few that stand out. One, we need to engage beneficiaries, their family members, and caregivers, especially those from groups that have been marginalized, in the design, implementation, and evaluation of models that integrate Medicare and Medicaid. We also need to ensure that their involvement doesn't add unnecessary burden and to ensure equitable ability to participate in the conversation. Two, we need to work to address beneficiaries' medical, behavioral, and social needs by forming community partnerships to identify community priorities, address beneficiaries' social risk factors, and connect beneficiaries with social services. Three, we need to prioritize developing an adequate and diverse healthcare workforce to meet the unique needs of dual eligibles in a culturally and linguistically appropriate manner. One example of this might be utilizing community health workers or peer counselors who are trusted members of the community to connect beneficiaries to services or act as liaisons between health plans and beneficiaries. Lastly, with respect to identifying and addressing health disparities, it's crucial to mandate the collection of high-quality data, including comprehensive race, ethnicity, and language data. It's also important to ensure that financial incentives align with advancing equity by linking provider payments to validated health equity measures. In sum, if we want to improve care and address the long-standing health disparities this population faces, we need to be intentional about incorporating strategies to advance health equity in our integrated care models. Thank you.